So what we're going to do now is we are going to move on to the next stage, which is we are going to showcase some podiatrists at work. And I've been fortunate enough to work with colleagues from Guy's and St Thomas's Hospital. And what they've gone and done is they have videoed podiatrists in action. So if we could bring down the slides deck, and I'm going to hand over to Gareth, Stockley and team. And what we've gone and done is we've brought in some colleagues who have actually done the videoing for us, and they're going to narrate. Now, I'm not sure which order we're going in, so I'm going to leave it very much. Hopefully, we can get the order right. That's I don't
fine.
Know who wants.
I'll introduce myself. I'm Aidan. I'm the first video today, so thanks for inviting me along today. I'm one of the MSK podiatrists here at Guy's and St Thomas's Hospital. So what I'm going to do is sort of narrate you through a sort of MSK assessment that we would do on a sort of a normal day in our clinic. If anyone's got any questions, if they could, I guess, pop them in the chat, and I'm more than happy to respond after I've finished talking through. And I think we'll be then going on to my colleagues, Nick and Tejal, who will talk you through some other days in the lives of the podiatry profession. So do you want to, Gareth, are you in control of the play button? Yep. Okay, so can everyone hear me okay? Yep. Okay, so what we're doing here is patient who we have here today who's come in complaining of pain in both feet and the heels. So what we are initially doing here is talking to the patient about her symptoms, getting a feel for the symptoms. As you can see, we're examining the patient's feet to try to establish where the symptoms are, what triggers the symptoms. As you can see, the patient's describing the symptoms she's getting to me as we're effectively palpating around the foot, trying to establish whether the symptoms are in the bone of the foot, the soft tissues, etc. We're also now having, very importantly, at how a patient walks to try and assess what their gait pattern or walking style looks like. We've got the options of assessing them, as you can see in the clinical area. We also have treadmills that we can use if we want to see the patients running. As you can see in this case, the patient has very flat feet in addition to some bunions. What we're now doing is looking at the function of the foot to see what the muscle strength is like, what the foot does when it fully operates. As you can see, just from looking at these feet, they are quite flat. So what we suspect is that the flat feet are contributing to the patient's symptoms by putting unwanted mechanical stress and strain on the feet, leading to stress of the tissues there, or what we would term sort of biomechanical misalignment. So our treatment plan, as you will see in a moment, is to try and address these biomechanical features through things like insoles, which I know the video will move on to in a moment. What we're doing here is loading up the feet to really appreciate what happens under load. What we've got here is the patient standing on what we call a foam impression box to allow us to match an insole to the foot type a little bit more accurately, and also in this instance to show the patient what her feet actually look like under load. It's very hard to look at your feet and appreciate what sort of foot type you've got, so we find that this really does help the patient appreciate how flat their feet are and why it could be a problem in this case. As you can see now, we're fitting up the patient with some insoles to try and address the flat foot and consequently improve the alignment and the posture in the foot, and then to try and in turn reduce the unwanted mechanical stress and strain that's occurring on the foot and contributing to what we suspect is causing her symptoms. So we've got the patient now in the insoles to make sure that she finds them comfortable. Obviously, there's no audio on this, but the patient did actually notice an improvement walking with the insoles. She felt more aligned overall. She's doing her shoelaces up at the moment, obviously. We'll see her work walking in a moment. It's just generally better having had the insoles on. While she's walking, we're explaining to her the importance of obviously wearing good shoes alongside the insoles. Very difficult, I know, to sort of appreciate the foot inside the shoe, but the patient did feel more aligned and more supported. What we would then do is get the patient with the insoles for the next 8 to 12 weeks or so. Either, whoop, there we go, done. Sorry, next one. Any questions in the chat for me? Thanks.
Okay, that's okay. Thank you very much. So let's do the next video. I think it's Nicholas. Is that right, Nick?
I'm up next. Yeah.
You'll go on then, Nick. Off you go.
Okay. So we get the video up. Yeah, hi everyone. My name's Nick. I'm a podiatrist working for Guy's and St Thomas's at our community sites, and I specialise in nail surgery. So we've hopefully got a video coming up for you. There we go. Yeah, so we undertake around about 20 nail surgery procedures every week, mainly for painful ingrown toenails on patients of all ages, really. And this procedure it's a type of minor surgery. It takes around about 1 hour to complete from the moment the patient arrives to when they leave. And here I'm just marking up the surgery site on the patient's toes. And today I'm going to do nail surgery on both of their big toenails. And that's because they've been causing her pain at the sides. And so there are 4 sides of toenail that I'm going to remove. And I'm just making sure that she understands the procedure. And off camera, we've gone through quite a few safety checks up to this point. And she's signed a consent form as well. Now we've got to the point where I need to numb her toes. So I do this with local anaesthetic. And this is really similar to the stuff that you might have had at the dentist. And there are 2 nerves that we have to knock out on each side of the toe. So there's one near the top, near the surface where the needle goes in, and there's one much deeper down at the bottom of the toe. But both of those injections can be, both of those nerves can be knocked out with 1 injection. So just doing the same thing on the other side. And we most commonly remove the side of the nail for ingrown toenails, but we can also remove the whole nail if that's causing painful problems. And this procedure is something that is covered in the undergraduate course. So you would be qualified to undertake nail surgery such as this after graduating with your degree in podiatry. There we go. And I've skipped forward a little bit here. Both toes have now had the injections, and we have to wait around about 5 minutes for the anaesthetic to take full effect. So here my colleague Ramesh is just testing around the toes with a pin, just to make sure that the patient can't feel anything painful. And once we're happy with that, we start preparing for the nail surgery. So the feet get painted up with some antiseptic. And in the meantime, I've washed my hands with some surgical scrub, got some sterile gloves on and all my PPEs. So that's the usual aprons, and we have a mask and a visor as well. And I do that before I set up all the kit here. So everything in this white pack here is all sterile. So at this stage, I'm the only person who can handle all of that because I've got my sterile gloves. So my assistant there, Ramya, is just going to be handing things over for me because I can't touch the packets. Okay, so once we're all set up, the first thing to do is to apply a tourniquet to the toe. So a tourniquet is just a really tight rubber band, and we push that over the toe. And what that does, that cuts off the blood supply during the procedure, and that prevents bleeding, and that allows me to see what I'm doing during the procedure. But it also, once the section of nail is removed, we put a chemical on there, and it allows the chemical to work without it being flushed away or diluted. And once these tourniquets are on, we have to keep a really close eye on the time so that we don't leave them on for too long. So we don't like to leave them on for more than 20 minutes, and that just prevents any sort of long-term damage there. So I've made a start now, and I'm elevating the toenail. So that's just means I'm separating the nail from the side, from the skin at the sides, from the nail bed underneath. And I'm using a really fine instrument here just to push down. The reason I use a little instrument is just so I don't disturb the main part of the nail bed. So I don't want to disturb that. I want to leave that all nice and intact. The only difference from that would be when we're obviously removing the whole toenail. We do the same thing just across the whole nail. Once that's done, we use a special pair of nail cutters. They're designed to go vertically down the nail, and that creates a new nail edge. We're just cutting that there now. And then I'll switch over to just a really fine mini scalpel, and I then extend that cut down under the skin, so we don't have to cut through the skin at all. Go down underneath and then through into the root and through the root of the nail. We call that the nail matrix. And once that's all done, that piece of nail is ready to come out now. So we just grab onto it with some forceps, and then it gets gently eased out. There we go. So that piece of nail out. Now I'll just move back to my vertical cutters. They're called thwaites, and we do exactly the same on the other side there. So we just take our time to line everything up, because each toenail grows slightly different direction. They have their own natural pattern. We try to respect that, just so it gives a more natural look at the end. So this procedure is called a partial toenail avulsion. So we're just removing the size of the toenail. And the next thing after this will be to put that chemical on. And that's called phenol. That prevents the section of nail removed from growing back, causing the same problem. So once again, just grabbing onto that piece of nail, which is now all separated, and just easing that out. Go. So I mean, patients often expect there to be a lot of pulling or tugging when we remove toenails, but this really isn't the case. I mean, so as long as the preparation's been done correctly, the nail should come away really easily. So it's much better to be gentle and slow, as the nail's often really fragile, especially at the root. And if it breaks off down there at the root, could leave some of it behind, and then it's going to regrow and the surgery would fail. So we don't want that. So again, just making a start on the other side by separating that nail there. And then I'll do the same as I've done on the other ones, which is using the cutters and the scalpels. And I would just skip forward a little bit here. So both, so all 4 sections of nail are removed, and I'm now applying that chemical. That's the phenol. So phenols are just a really strong acid. It's called carbolic acid, and it destroys the root of the nail. And what we do is we apply this for 1 minute, and then we repeat that 3 times just to make sure it's definitely had effect. That just means those 4 bits of nail that I've taken out, they can't possibly grow back now. Okay, so we've just pushed forward a little bit, and that's the last application of phenol. So we've done the 3 minutes, just taking off last remnants of the phenol, and that's the surgery complete. So the only thing we've got to do now is get those tourniquets off. The easiest way to do that is just cut them away. And then we record the times that those tourniquets have been on. That all gets put into the notes. The notes for nail surgery are quite extensive, recording lots of different things. And then as soon as the tourniquets are off, the blood can return to the toe. So it usually starts bleeding fairly quickly. You can see a bit of blood there. And then it takes a couple of minutes or so just to apply a bit of pressure to get that bleeding to calm down. Then we can start applying the dressings. There's quite a few layers that go on. The dressings are quite chunky straight after the surgery. But the patient can walk afterwards. So we like them to go straight home, lie down for a few hours, take some paracetamol if they need it. It's not usually a lot of pain after this type of surgery. And they usually then come back to see us 2 to 3 days later for a checkup and a change of dressing. And we make the dressings much smaller at that stage. So usually they can then just resume normal activities after that redressing appointment. And we normally discharge them, and then they look after the toe themselves until it's fully healed. And that takes around about a month. So there we go. I mean, I find nail surgery one of the most satisfying things you can do as a podiatrist, especially if you're quite dexterous with fine motor skills. I regularly see patients who are in quite a lot of pain, really apprehensive about the procedure. I mean, within an hour, you fix their problem, hopefully, and I find that incredibly rewarding. So just putting the last bits of the dressings on. And yeah, I hope that's been interesting to see some of the type of work you can do as a podiatrist. Thank you very much for watching.
Thank you. No, that was really interesting. No, very, very interesting. Yeah, and I'm sure it's an essential part of ensuring that people are able to maintain mobility in a way in which gives them a lease of life, which is important. Right, final video. So over to Gareth and final colleague. So do you want to
Hi. Hi, my name's Tejal. I'm one of the podiatrists working in the hospital settings. So I specialize in wound care. So I'm going to show you 3 videos of a dressing that a treatment plan that we would do. This first one here is, you can start that, Gareth, is called total negative pressure, and it's using a pressurized dressing to suck up all the discharge using this special sponge and the canister, which you'll see at the end. It kind of speeds up wound healing. So this is one of the very common ones that we tend to use in wound care. For surgical sites, or in this case, a surgically debrided site which had got infected. And we normally have it at a pressure of 120, which is the common one for an optimal wound healing bed. That's usually applied for about 4 or 5 days, and then it's changed, sometimes up to 7 days. The canister is then changed as well. The second one, Gareth, is a casting technique that we tend to do. Now, this one is for somebody who may have an ulcer on the bottom of the foot, or it may be an offloading device for a Charcot foot, which is one of the complications of diabetes. You can see that they're protecting all the prominent sides so that the cast doesn't rub. And the whole leg is then wrapped with soft band. And a special casting tape, not plaster of Paris, but a lightweight casting tape is then applied, just like as if you've broken your leg. And that stabilizes the foot and the leg in a certain position, and that tends to offload and speeds up healing. This is also one of our very common treatment plans, and obviously it is time consuming, but you can see that this patient has got a little bit of a bowed leg, which is very common. The third one, and finally, Gareth, sorry, is our larvae treatment. Now, this is a green bottle fly larvae. Sorry, not this, but it's going to start in a minute. That is cultured in a sterile field. It is a bio bag, which means that it's sealed in a bag and applied. And it's really great for eating up all that fluffy wound. It cleans it up very quickly. And then once you've got healthy red granulating tissue, it tends to heal up really well. We just put a little bit of pseudocreme around it just to protect the surrounding skin, because the larvae does produce a lot of discharge, and that just protects it. Patient just leaves it alone. If they're leaving it on for about 5 days, we do tell them to make sure that they just moisturize that gauze a little bit, just so that the larvae are hydrated. But it's really, really good for cleaning wounds. It reduces the use for antibiotics. Yeah, that's it. Sorry, that was really quick.
That was amazing. Absolutely. All three amazing. And I think that shows the diversity that podiatry has. You know, it's the lower limb. And I think that's what we were showing there. It is the lower limb, you know, from the work that Adrian showed, the biomechanical side of it, or the MSK that we've heard today, the term musculoskeletal, that's what that stands for, you know, to the work that Nicholas showed. That is definitely important work, because, and it shows you the importance of feet are to us. And then your work there, Tetra, that I was blown away by that. I didn't realize that. I've obviously seen many a wound, but the advances within podiatry now are totally amazing. And I think I'm sure for all of you, it's great to be at the forefront of what's going on.
Yeah.
Would you agree?
Absolutely. And I mean, in my case, because I'm based at the hospital, we do a lot of work like with the other professionals, like the vascular surgeons, the plastics, the diabetes, the physiotherapists, and it's joint working, holistic approach to that patient care. And we're always learning new things. There's new techniques that's coming out, and it's just so interesting. It's absolutely fantastic.
And it's interesting what you said, Adrian. As soon as you'd managed and you'd altered the foot and you'd done your foot, that patient fed back, I feel much better. And I'm sure that must be so rewarding to know you've made such an instant input.
It is. It makes it is rewarding, and it's great for the patient, because a lot of people are, you know, can't do what they want to do, whether it be in life or work or whatever, if they've got sore feet or sore ankles. So to sort of help as much as we can, is great, really. Certainly in the current climate.
Yeah, particularly. Yeah. And I suppose again, Nicholas, from your perspective, if somebody is reliant on being able to work, we are making a difference to them being able to maintain, support the economy, etc., from that perspective.
Yeah, absolutely. I mean, often we see patients who, yeah, they've been off work for a while, or they've been off school. They're in a lot of pain, and like I said on the video, just being able to turn that around and sort that, particularly with the nail surgery, and fix that within an hour. Very, very rewarding. So yeah, I mean, I've come into podiatry from a different profession. I've been doing it 15 years now, but I've never looked back. I absolutely love the work that we do, and you know, such a large scope of practice that we're able to do. It surprises a lot of people when they find out about podiatry. You know, it's not just obviously cutting toenails, but quite a lot of people think that it is kind of just that, and it's far, far more than that.
No, it's definitely it's lower limb support, basically what we're looking at, and you work very close. And it was interesting because in some of the videos you were working with colleagues, you had colleagues supporting you, so it becomes a team. It becomes a team to move it forward. So brilliant. I'd like to thank you particularly for the time and effort that you've put in to create those videos. We're overwhelmed by it, and I'd like to thank you for your support today. So I'm going to let you go back, because I think you've got the day jobs to go back to now, which I know you obviously do enjoy. But thank you very much for your time. We do appreciate it. Okay.